it is a huge, huge honor today to be podcast interviewing my buddy Jeffrey Krupp. That's how you pronounce it, right?
Yeah,
Krupp.
Jeffrey Krupp. That's
And
right.
just a month ago, we were having a beer in San Jose, and I wanted to podcast you so bad. I think you're the coolest endodontist I've ever met.
Thank you.
And when these podcasts, I mean, seriously, they're mostly devoured by the kids. I mean, they're all either juniors or seniors in dental school. I've been
Well,
out
good for
5 years.
them.
Every time someone sends me an email telling me they love my podcast, I always reply back, "Oh, well, tell me about you. What are
Right.
you, a boy, girl, how old, whatever?" They're all kids.
You're right.
And you've been an outstanding, stellar endodontist for what? How many? 30 years? I don't want to give away your age.
I started practicing in San Jose. I've been at the same location since July of 1982, and I joke around the fact that Ronald Reagan was president, America was strong, the dollar was actually worth something, and I really can't believe I've been at that same location for this live 33 years. Yeah.
So was your favorite song of all time written by Dionne Warwick? Now, none of the kids, not one listener. There's 7,000 listeners. I bet not one person gets that joke. What's the joke?
Do you know the way to San Jose? Yeah.
That was a great song. And Whitney Houston ended up being her niece or her sister's daughter or something like that.
Yeah,
That's just
some tie-ins.
Yeah, unbelievable. But you know what? When I talk to the younger dentists, I mean, they're really not freaked out about implants because they're not doing them. They're not freaked out about 3D CBCDs because they're not doing them. What they're really doing is fillings and crowns, and that's manageable. I mean, you can't get in too much trouble during a filling and crown. But you know what's really kicking their butt is molar endo.
Yeah.
And from the diagnosing, the treatment planning, the whole 9 yards. So, but my first question to you, I want to ask you is this is the thing that no one wants to talk about with endodontics is that, being a fireman, you want to put out the fire. Being a policeman, you want to catch the bad guy. A dentist wants to save a tooth. And sometimes I had this old gruff endo instructor at UMKC from 83 to 87, and he'd hold the PA at an arm's length. And he'd say, at an arm's length, if you think it's in, do the root canal. We don't sit around and love pulps and dical and slow speed. We don't worship pulp. If it's in, kill it. And sometimes they get burned because, they're in there with a high speed. They switch to a slow speed. They're down to hand instruments. Then they think, is it affected or effected dentin? And they put some dical, this, that, and then the thing blows up. So so if you were a young kid, if you were talking to me and I was 25 years old and just walked out of dental school, how much should I worship the pulp? And when do I just say, the hell with this thing, I'm going to kill it?
Well, I'm a very conservative. I'm a very conservative endodontist. My diagnostic protocols are centered around the fact that pretty much I believe we could always do the root canal tomorrow. And I am not aggressive. In fact, I get accused of being not aggressive in the slightest. And I'm very comfortable sleeping at night with that position. I like to be able to absolutely verify the symptoms in the chair. I mean, if I can't get that patient in the chair, they can have subjective symptoms, but I can't duplicate them in the chair. I am not going to numb them up and start a root canal. And I'm, again, very comfortable with that. I have seen far too many patients treated that didn't need endodontics. I had a patient today, as a matter of fact, came in. She was in last Thursday. Really beautiful British lady. She had an amalgam that was probably so heavy the right side of her face was hanging, and it was old, and it was on tooth number 2. And I looked at it last Thursday. I mean, you could almost say for sure there's recurrent decay around the mesial or the distal, and it's cracked. And I don't see how they were able to keep such a large alloy in that tooth for that length of time. But I did some percussion testing, we did some cold testing, we did some vitality workups, we took a PA, and as a matter of fact, she just wasn't having the subjective symptoms. Duplicatable, it's a hard word to say, in my chair. Well, she showed up this morning, and she was in a lot of pain, and it was tooth number 30 with the recent PFM that had just been done this last spring. And I went, see, that's why we wait. Because patients do not like multiple procedures for a single tooth problem.
So So you just opened a Pandora's box, talking about a crown.
Yeah,
There,
it was a
there,
beautiful PFM. I mean, it was
there
gorgeous.
there are people that say a third of every tooth we crown within 5 to 10 years will need a root canal. What do you think of that number? Is that
You
right
know,
on?
I
Too high? Too low?
well, I don't really know the numbers on those things. I mean, as a practicing endodontist, I would say it's a little bit around who's doing the preparation. It's a little bit how fast are they running those burrs? Were they Howard, I see a lot of crowns. I'll take a temporary off, do a root canal, and I'll see an old alloy underneath it. And I'll say, my goodness, the patient was anesthetized. How do they know there's not diseased dentin underneath that existing alloy that was placed when they were 14 or 15 years old? If you're going to go ahead and prep something out, remove everything. Get your carie stain out, stain it, make sure you're good before you build it up and then go ahead and prep your tooth. And I just think that there's no excuse in my book for leaving an old alloy as part of your core for a new existing crown. You don't know what's underneath it.
Yeah, I always, if I'm going to work on a tooth, take everything out.
Just go back to solid dentin.
Yeah, I completely agree. So what do you think? Doing this for 3 decades.
Yeah.
What do you think the young kids? What do you think the low hanging fruit is? What were the mistakes you were making when you were in your 20s
Okay.
that now
Well,
you don't make?
yeah,
That
I
you're
started.
39.
Yeah, I started when I was 28 as a full-time endodontist, and it seems like a long time ago, and it seems like it wasn't so long ago. But I would say that probably one of the biggest problems that endodontists have, and I would go ahead and extrapolate that a general dentist has, is in getting teeth numbers 18, 19, 30, and 31 numb. I mean, those patients come in and they have a blistering, in dentistry, we call it the hot tooth. They have a blistering problem and it's legitimate and they are not anesthetized. Now, at that time, I didn't have the armamentarium that I use now for numbing teeth up. I just didn't have it. And oh my God, the blood we used to sweat trying to get these poor people numb when they had just such a hyperemic, acute irreversible pulpitis and just a terrible problem. Terrible. And I would say that was, now I can sit down with a high degree of confidence, almost cocky confidence, and say, "No, you're going to be numb. If you're not numb, we're not working on you." It's a black or white issue. I do
And
not work on
is it
people.
because you've changed anesthetics or you change your
Well, I mean,
technique or?
you get better. You just get better. I mean, numbing people up is a little bit of an art form. Everybody's jaw, everybody's ramus, everyone's internal pterygoid muscle. I mean, there are different ways to go around it. I utilize a protocol that brings in a Gao-Gates injection. I'm using a lot of Septicane. And we get people numb, and so many people come in. Oh, I couldn't get numb. I can't get numb. And these poor people have been so afraid of the dentist for so long. I'm sure you've seen them in your office. They come in and they're just mortified, but generally discomfort and acute pain is what's brought them in. And their poor teeth are just wretched. Their things are broken, things aren't repaired because they're just freaked out.
Speaking of freaked out, some people are freaked out of using Septicane on the lower because they think they're going to get some nerve
Yeah,
devastation.
yeah,
What
yeah.
do you think of that?
I use it routinely. In fact, there was just an article in the Journal of Endodontics a couple of months ago, and they were talking about the attribute of using 2 carpules of Septicane as a block injection over 1. And I think that's 3.6 cc's of articaine. And you know what? I do it routinely, and we'll find some wood around here. I have not had any problems. You got to give it. I administer it slowly. I administer it carefully. I administer them one at a time generally, and the stuff works. I saw an article. Whoa, I don't know how long it was, 17, 18 years ago in one of the throw magazines that came across our office, and an article out of France, and it says, "Oh, we have an anesthetic that has a little lipid moiety on it, and it actually floats into the neurologic tissue, and it really gets people numb." And of course, at that time I was like, I'm trying anything. I mean, at that time I was punching little holes back with, remember that little perforator burr, hoping that there was a extraction socket that wasn't too ossified. We could get our little plunger in there, and that worked pretty well, but that made me nervous. So I went ahead and tried this Septicane product very soon after its introduction, and I went, oh my goodness gracious, this stuff is better. And I, spread the word all around my referring community, and now I think it's become pretty well.
What do you think? What do you think? Some people, when they got a hot tooth on a lower molar, after they give their block, their inferior alveolar block,
right?
After about 3 or 4 minutes, then they'll go take a ligament jet and start ligging all around the tooth. Do you ever do that?
No, I don't use a ligament jet. Never have. I don't like to use a ligament jet. It looks too much like a gun. It's too scary, and I've never really had much success with it.
Yeah.
I typically will use a wand, and I'll use a Gaugates approach, and I will use Septicane, and I will use, prior to that, a compounded topical that I leave on the tissue, which is, I don't remember the exact ingredients, but 3 different type ingredients that are in there. Works very, very well. We add a little bit of the commercially available topical to sort of increase the flavor profile of the stuff, because it doesn't taste very good. In fact, I think we get out of a pharmacy down there in your neck of the woods. And that works very well. And then just, slow by easy by slow. Just anesthetize them slowly. I cannot stress that enough. And the wand really will allow, it has a little computer chip in there, and it allows for an even flow, the deposition of the anesthetic into the tissue. And it's really us picking up our anesthetic carpule and going wham, that's really what brings the discomfort in. It's not necessarily the needle per se, it's the flow of the solution being injected quickly into the tissue. And I joke with patients, yeah, remember when you were a kid? And I don't think any of the kids listening to this remember this, but doctor would have you drop your pants and he'd load up how many cc's of penicillin and load them right in your butt as fast as you can. You go, yo! That's what it is. It's the tearing of the tissue by the solution going in. But I use a wand, and it works very, very well, and I use it slowly.
That would be a good C course. If I remember right, is Smart Practice here in Phoenix, are they the ones selling the wand now?
I'm not exactly sure who the wand, I have my manual here. I could look it up, but the wand is a wonderful tool. I like to say that I got it for the patient's comfort, but I didn't. I got it because I was starting to get some discomfort in my thumb. And one of my office people said, "Hey, Dr. Krupp, check this out. The wand is manufactured by Millstone Scientific."
But is it just, do they sell it direct, or do they sell it through distributors?
I don't know. I don't buy anything in my office.
Yeah, same here. Yeah, same here. I have no idea. And I don't think a successful dentist spends all their time trying to save 12 cents on gauze in a catalog or online. I mean, I think that they missed the whole boat. I mean, really, if you're buying anesthetic and gauze online, I think you missed the whole boat. Let's go to radiographs. My job is trying to estimate the questions. I got about 7,000 listeners per show, and I believe they're all 5 years out of school and under. One of the big stressful things they're having is, they come out of school with $250,000 of student loans, and some people are telling them, to do a root canal right, you need to buy $100,000 three-dimensional CBCT X-ray. Right. Can I do quality molar endo with 2-dimensional X-rays, or do I really need to suck it up, buttercup, and get me a CBCT?
No, you do not. If you're a general dentist, I mean, I recently digitized my office just this last spring. In fact, I was one of the very first clinicians in Silicon Valley, if not the first, to buy myself a digital imaging system back in 1992. And I had this fancy digital imaging system, and the sensor was about as big as a brick, and the fidelity it was bad, and the fidelity of it was marginal. And I mean, I'm an older guy. I was raised on film, and I mean, if a film is properly angled, it's developed properly, it's fixed properly, it's dried properly, yada yada, then it's going to work very well for you. But the younger people listening probably don't even know what film is. There also used to be something called vinyl records, which also sound really cool. But analog, film works really well. Well, I went ahead and I'm always looking at the new stuff that's out there. I'm always interested to see what is being developed. And I kept my eyes on the digital assistant. Oh, needless to say, my first digital imaging system, it has been up in my attic for a long, long time. And I went back to the exclusive use of film. It was just too uncomfortable, and the fidelity wasn't good enough. So I was the first one out of the box with that, and I ate it. I spent a lot of money, and I did not enjoy the thing. But now the fidelity of these digital imaging systems are fantastic. I have now a digital imaging system. I use it routinely. Patients still complain a little bit about it with trying to have it placed underneath a rubber dam because it's still a little uncomfortable. Film is still thinner. But obviously the attributes to it, your image quality is just as good as film, if not finer. Your ability to manipulate the images is wonderful. Storage, and then of course the reduced exposure time, it's terrific. But as far as going out and getting a CBCT machine to do endodontics, no, I just got one. I got one in the spring, and I use it, and I've heard you interview other guys, and other gals. We use them primarily to evaluate retreatments.
So what machine did you get?
Carestream 8100.
That's what I got too. That seems to be a pretty popular one.
Yeah, I got it. I want to say I did a whole bunch of research around it, but I didn't. I had my eye on them again. I keep my eye on a lot of stuff, and I had seen them come around, years and years and years and years ago. I went to a lecture, and they said, "Oh, there's going to become a technology when you're going to be able to three-dimensionally evaluate your tooth or your jaw." And I went, yeah, sure. Beam me up, Scotty. I had no idea that I was going to live and practice long enough to see this technology. So we had a junk room. We cleaned it up. It used to be an old operatory. It worked beautifully. We put it in there. The Carestream, you enjoy your machine? It's wonderful. I don't do implants in my office. I don't use it for that purpose. But for evaluating retreatments, you do see cases where you're having trouble perhaps finding a canal, and you can take them over there, explain the situation to them, and then run a cone beam on them and go, whoa, I just need to go a little bit there, or I need to go a little bit there, and it saves removal of unnecessary dentin down the root face. So it helps you be a little conservative.
Some of the kids, I watch them talking on the message boards, and I watch them bantering back and back. And a lot of I think what stresses them out is when one will tell the other, and they say, well, the number one cause of root canal failure is missed anatomy. If you would have had a 3D X-ray, you would have seen there was an MB2, or you would have seen another canal. Do you buy that argument? Or
well, to a degree. There's a study by a guy named Kulik, came out years and years ago, and he says that 90% of all upper first molars have MB2 canals, and they probably do. He's probably right. They do. Do you need a cone beam to know that 90% of teeth have MB2 canals? No. Do you need a cone beam? Do you need a cone beam to find 90%? Not really. What is best is to take a very careful, calculated look in that area where you suspect the anatomy might be. If you're not looking for it, you're not going to find it. The one constant, though, in endodontics, and you've heard other endodontists talk about this too, is variation, not only to root morphology, but also to canal anatomy. That is the one constant that's not going to change in our business ever. God's throwing curveballs every day at us. Before I came home to do this interview with you, I was working away on this British lady's tooth number 31, I forget what it was. And it presented anatomically as though it had, one little dark line running right down mesial distally, had a nice distal canal, had a nice mesial canal. And I thought, this is one of those unusual, although you see them, two canaled lower molars. And I was working away, getting ready to fill it. And I got my scope out, because I generally push my scope away after a period of time on my procedures, brought my scope back in to take a look at it. And sure enough, right there, I was working down the mesiolingual canal. The MB canal was right there, sitting right next to it, like the Twin Towers. And I went well, there you go. They're there, and they're constantly trying to fool you. So you want to do a very thorough evaluation visually for any further anatomy, any further orifices. You need to open a tooth up. You need to see what's going on. You need to get through and give yourself a chance to get light into that tooth and give yourself a chance to find that anatomy, because by and large, it's going to be there.
Now, you said this lady was from Britain, Great Britain.
Britain, she had a beautiful British accent.
And I assume she was a foreigner because I assume that all endodontists only treat foreigners, because when I talk to the 120,000 general dentists doing root canals, I ask them, what is your failure rate? And every single one of them will say, well, knock on wood, I've never had one fail yet. No, and then you go talk to the 4,000 endodontists, and they're either only doing immigrants from other countries, or these general dentists don't realize some of the root canals fail. I want to ask you, of the 4,000 endodontists in America, what percent of your work or cases is retreats done by a general dentist that failed earlier? Because seriously, go ask 10 general dentists how many molar root canals they've done that failed. And most of them will say, you know what? I knock on wood. It's
haven't
never
done
happened.
One yet.
Yeah, I haven't done one yet, and I've done it for 30 years.
Well,
so what's the beef? Who's right or who's wrong?
Well, I mean,
do these guys never fail, or are you guys only working on immigrants?
No. Teeth fail. I mean, that's part of why I, produced what I produced. I mean, teeth fail. There certainly is probably historically been some very large studies around endodontic success. And I would say that probably in large numbers, the success rate is, I recalled about 82%. 82%. Over what length of time, I can't tell you, but 82% seems pretty darn reasonable. It doesn't seem as though, because there's only an 82 chance of success, we're just going to take the tooth out and do an implant. I don't think that that's a reason. The root canal might fail, so let's do an implant? No. God put the tooth in there for a reason.
Yeah, the dental elf just had his monthly deal this month was that implants are failing much higher rates than anybody's reporting. And I think what the implant companies, they all do, they always show their success rates based on implants in the lower mandible. where basically a nail from Home Depot or Lowe's would work. I mean, you're sticking titanium and oak wood, but they don't seem to incorporate into their studies posterior mandibles, the maxilla, sinus lifts, bone grafts, but basically what everybody's critical research is saying that implants fail much higher than anybody's reporting.
Well, I mean, obviously, implant is a wonderful restoration. I mean, it's a wonderful advance in dentistry, and I'm not trying to malign implants at all. I don't place them. I respect the guys that do. I see beautiful results from ones that are done. I see results that aren't so good also, and as I'm sure you do in your practice. I saw a lady the other week that had a beautifully placed tooth number. She was edentulous. She had the implant in the 31 area. It was beautifully placed. It was integrated. It had been unloaded for 5 or 6 years because it was pushed so far distal that there was no way they could get a distal margin down on the crown. And so it shall remain as her implant without any function. I believe I read something recently in the CDA journal that they were talking about 60% of implants had cracks in them. I'm not sure how serious those cracks are, but I'm not maligning implants. I think it's a great restoration. I think it's they need to be done with, like any other aspect of dentistry, they need to be done properly, treatment plan, probably put in with some surgical guides and restored by guys that really know what they're doing.
So let's give some father-son advice. I want you to talk to all these 30 denters listening here, because one of their stressful things they're saying is what is someone like you who's been doing this for 3 decades thinking between when you're looking at a retreat or extract an implant?
Yeah.
How do you frame that diagnosis and treatment plan?
Yeah, I mean, again, today I got into a tooth, a wonderfully beautiful lady, 5 months pregnant. She waited till her middle trimester for me to go after her failing tooth number 30. And I was like, okay, great. This is going to be interesting. And I think every endodontist, and I can speak for a lot of endodontists on this, do not like to open up a tooth and see little circles of gutta percha with a black eye in the middle, which means that we've just run into one of these gutta percha on a stick obturator systems. Oh my goodness.
So are you talking Thermofill?
whatever nasty event you want to call it. I call it gutta percha on a stick.
But is
And
that that's
yeah,
that's
that's a
most
thermophil. That's a
but
thermophil.
what percent of the gutta percha on stick would be thermophil?
Well, I'm not sure what percentage, but I mean they've gone to gutta core now to try to get around that. But for a while there, these thermophils were getting stuffed into teeth with, and it's just they are very difficult to treat. They are very difficult. They look like gutta percha on a radiograph. You can't see the difference on a scan, and I just am not comfortable retreating those things. I would rather see silver cones in there. At least a silver cone, I know if I can get it out, I've pretty much got the cone out. A thermophil leaves residue of gutta percha or this and that, and it's not a good prognosis with a thermophil. And so I would say that by and large, I am not one of those guys. I'm conservative. I'm not one of those guys where someone presents with what appears to be a reasonably well done root canal and say, yes, I can fix that. I mean, I'll give it a try. I'm patient centric. I will definitely try to do what the patient wants to do. I mean, but I will give my clinical advice and I will explain the different parameters and for sure the options to what they're considering.
So, that's something that dentists have to think about. I mean, of course, a root canal is going to fail because we're all going to die. I mean, I'm not sure anybody's made it past 115 years old. Yeah. So if every tooth we touch is eventually going to, every time we touch a tooth, we condemn it to retreatment if they live long enough. And you need to be looking at treatments that are reversible. I mean, sometimes we're wondering about this with these new zirconium crowns. I mean, you bond on these zirconium crowns and sometimes you go to cut them off. I mean, it's literally almost impossible to remove.
Oh yeah, I accessed through quite a few of those sparkers. Yeah. I'm not sure why porcelain needs to be so hard. I don't think the human dentition really requires that, but they are some mighty, mighty, mighty strong pieces of porcelain.
And I think that's
or
why
maybe even they're calling them metals. Zirconium's a metal, I guess.
And that's why a lot of surgeons are telling me that porcelain cosmetic implants are dead on arrival because when porcelain glass fractures under the jaw, oral surgeons and periodontists saying that's a mess.
Yeah.
And they would rather grab onto a solid piece of titanium to get it out, not some breaking piece of glass.
Yeah.
So right. So retreat. So humans love lists. They love the top 3 this, the top 5. They love top 10, even the 10 commandments.
Right.
Went with the top 10, even though it's not even 10 commandments, because they seem to be a lot of duplicating. Thou shalt not commit adultery. Thou shalt not covet thy neighbor's wife. Thou shalt not steal. Thou shalt not covet thy neighbor's goods. It seems like a lot of repeats in the 10 commandments. But if you had to have a list of like the top 3 or the top 5, what do you think a 30 and under kid that just got out of dental school, they haven't done 50 molars yet, what do you think will be the top 3 or 4 or 5 reasons their mistakes? Will it be
where are they going to find their mistakes?
I mean, yeah, what will be the mistakes they'll have to learn?
Well, that's a great question, Howard. I mean, what I discussed earlier, not making sure that patient's numb, that is absolutely paramount. I mean, it seems like a given, but make sure they are numb and that they are not feeling this procedure. The patient needs to have confidence in the clinician so that they come back, and you do not want to scar that patient into the future for their inability to walk back in a dental office. We want to make sure they're numb. The other, and another very key, I don't want to call it a mistake, but let's just say it a clinical challenge that I see, is they're not opening up the roof of the chamber. They're not getting these things open. They're not truly allowing light to come into the chamber and evaluating the floor of the tooth for any further anatomy orifices. That's another key problem that I see. Another problem that I'll see is they're not removing restrictive dentin. I mean, there's a whole debate going on in endodontics, and you might have heard some of these terms, ninja axes, and let's be conservative, and let's be open. And I mean, oh my goodness gracious. I had a professor many years ago, a very wonderful endodontist, who told me when I was a resident that there really isn't anything conservative about an endodontic procedure. And not that you need to rip open stuff needlessly, but I use the term, when I teach, I use the term maximize your minimums, minimize your maximums. Try to make sure that you're open just enough to make sure that you're not hiding, there are no orifices are hiding there, but at the same time, don't take it at the expense of solid dentin. So between numbing people up, opening up the chamber and evaluating for any further orifices, that's two. The third one I would say would be do a little pre-flaring to your preparation prior to getting your measurement. Because I was measured down to 22.4 millimeters or 22.5 millimeters with my number 20 instrument on the mesiobuccal canal, and they weren't numb enough, and I didn't know what to do. And I'll get long notes on my referral cards about how they were so careful with this and so careful. And God bless them. I think they were trying really hard. But I go and I open up the tooth and I go I take the temporary out, and I've got a mesial shelf of dentin just going wham, hanging right over here. I'm going whoa, what's going on here? And the first thing I'll do is take a carbide fissure burr that's tapered, round-ended, and I'll just open that thing up and flare it up so we can get in there and see give yourself a chance going into these teeth. So people are working through a lot of restrictive dentin in the coronal third and even in the mid-third. You want your working length instruments to drop nicely to the root end so you can get a proper root length evaluation and if you have the luxury, you're not working through a new porcelain crown, an old alloy or some other type of crown, you have the luxury of flattening off that cusp so you have a predictable measurement point for your further instrumentation. Do it. Take advantage of it.
Well, I can't ever interview an endodontist without asking him the obvious, the $1,000,000 question. Where does the root canal stop? Are you an apical barbarian?
Yeah,
Do you like to
use that term.
get out? You like to get a puff of sealer out the end, and you love it, or are you a pulp lover and you like to stop?
Well, you know
before
what?
the apex.
I'm just me. That's
You're
all.
just you?
I'm just me.
Would your wife call you a lover or a barbarian? And we'll just assume it's a root canal.
Yeah, right. She probably called me a little bit other things, but anyway. So.
Well, where does the root canal end?
Well,
and
the
like
root
say,
canal
do you want to puff a sealer out the end, or or is that
if you get it, you get it. If you don't, you don't. I mean, it's not something I'm shooting for. It depends, I think, how long standing that lesion is. They call them LEOs, lesions of endodontic origin. It depends how long that tooth has been infected. It depends what the body's trying to do with that contaminant. If you're finding yourself getting, a nice puff of sealer through some tertiary anatomy that you had no idea was there and most likely is there in most of your cases. I cannot stress that point more strongly. I mean, there's some wonderful diaphanizations that are going on these days. Go online, look at some of these clearings. The root anatomy, particularly as you get to the middle and especially into the apical third, is extremely complex. Herb Schilder had it right. He brought the word, root canal systems into our dialogue, and he's absolutely right. In dentistry, we were working with the concept. I don't know, you're probably even a little too young yourself. The Washington Monument theory. We're just going to go down and we're going to carve out this trapezoid apical seal, and we're going to. I think that came from silver cones. I'm not sure, and that's what they're going to look like. They're going to look like the Washington Monument. Well, wake up, dentistry. That's not the way it's going down. God has thrown tremendous variation into. No talk on endodontics needs to begin or end without an amazing discussion or certainly amazing pictures of what's really going on. And like I said, I've got some pictures here in my program, but you can go online and look at these diaphanizations that are coming out now. This was exposed early in dentistry, 1913. Hess showed this in Dental Cosmos. I mean, that we're dealing with amazing variation. So as far as going, how do I treat the apex? I like to just, make sure that I'm getting an extremely accurate root length measurement. That's where the game starts. After they're numbed up and you've identified canals, clearing out the restrictive dentin, getting an accurate root length measurement, and creating a glide path and maintaining patency. I mean, it's not a complicated concept in endodontics. It's technically very hard. It can be challenging.
When I saw the internet came out, I thought the internet solved an amazing problem. I thought dentists were all professionally isolated and lonely. Not really many people they can talk to. Yeah. And they're shy introvert people. And when they go to a dental convention, when they go to CDA up there in San Fran, there is more file systems being sold than they could name cousins and relatives. I mean, there's just so
Yeah.
many, and they're all alone. So I want you to give some guy, think about this 30-year-old woman walking into the CDA, and everybody's trying to sell her
Yeah.
a file system, and you're
Yeah.
her,
Mine's the best.
you're her dad.
Mine's the best. Mine's the best. Yeah. You hear
Wow.
that from everybody. It's just
So,
amazing.
so what
Uh,
would you, what? I don't want her practicing alone. I don't, and she feels like it's hard to trust someone. The research we see is, dentists about 94 to 97% would rather take the advice from a colleague than a salesperson. They think the
oh,
salesperson's trying to sell on their deal. They're not going to sit there and say, "Well,
yeah.
here's."
Yeah.
So help her out. What file system are all files file? I mean,
Well,
I'm sure Tiger Woods could golf better than me with a used set of clubs from a garage sale.
I used to caddy. I used to caddy, and I got to be a really good caddy. And I would see these guys go out on the golf courses, and oh my goodness, what a difficult sport that one is. And that's supposed to be for fun. So I like to walk the golf course, but I won't play it. As far as file systems go, it's how you use them. They're all so many people are putting so much thought. I received, I think it was John McSpadden. I'm not sure exactly when it was. It might have been 1990, 1991.
I
And
love that guy. I
a
love that
great guy. And I've met him, he doesn't know me real well. I don't know, but I've met him. And I got a little card with this file. It was the zero point .02 nickel titanium flexibility, was martensitic and austenite properties. And this baby you could bounced right back. And I went, whoa, and I'm hand filing with stainless steel, K files at the time and doing different things. And I was just amazed. It was incredible. It almost seemed unworldly. And, dentistry and the manufacturers that are out there. I mean, God bless those guys. They're out there really trying to make our job easier. But at the same time, they're inundating us. And this one's got this file system and this one's got this file system. And, it's how you use them. And it's at what point in the procedure that you use them. I read an article just last weekend of another new file system coming out. And this was an article that was about a half-page article, and it was written by a dentist, and he was extolling the benefits of this next new. I think there's 60 or 70 file systems out there.
Isn't that amazing?
60
or 70.
Yeah, it's crazy. Nickel titanium. Now they're heat treating them, and I kind of like the fact that they're heat treating nickel titanium. But anyway, so this file system was being extolled by this dentist, and I read the article, and I read a lot of these articles, and part of the praise of the instrument was he mentioned the word quick 8 times. He mentioned the word irrigate 1 time. That's where I think the culture of dentistry needs to change in endodontics. Because the file, yeah, we pick up some pulpal debris and we probably get some bacterial contaminants and we get, thises and that's out of teeth, and we've all seen them. But really, when the rubber meets the road, it comes down to activating your irrigants and getting into all these amazing anastomoses, all these tertiary anatomical variants that are just everywhere on a daily basis. They're out there. These roots are complicated. When I was first in my endodontic program, we were laterally condensing. We were K-filing and we were laterally condensing. And every now and then we would get, with our Grossman sealer, we would get a lateral puff out the side. And I had this one endodontic professor that swore that tooth was going to fail because that's evidence of a broken root. Come on, I saw Herbie Schilder. I'm not a student of the Boston program, but I saw Schilder interviewed probably about 1980, 1979, and a wonderful speaker. And he's given so much, and his students have given so much to dentistry. And he really, like I said already, he brought out the concept of root canal systems. And they are systems. And I'm going to say it again, and every endodontist will tell you, these are complicated roots. Morphologically, maybe it's a single root, but anatomically, they are complicated. Morphologically, they may be more complicated than you see, like you expressed on a mesial distal 2D radiograph. But no, I don't think you need a cone beam to show that necessarily.
And that was really the problem with thermophil, is that people didn't spend any time cleaning and shaping, because with that carrier, they could shove it to the apex.
Let's do it faster.
And it looked great on an x-ray. And it's like the whole deal of endodontics assesses what you take out of the tooth, not what you put in. So,
Absolutely.
since irrigation is so important, let's talk about that. Is your main irrigant bleach, sodium hypochlorite?
Sodium hypochlorite,
Do you
yeah.
use EDTA or chlorhexidine gluconate or
I
any
don't use
others?
chlorhexidine. I use EDTA, ethyl diamine tetracetic acid. I use it towards the obturation portion of my procedure. But I believe that for me, what works best is activating, using ultrasonic activation of the sodium hypochlorite. It needs to be activated. That's
To save money, what I do is I just shake the head.
yeah, or have them bounce up and down. Yeah.
Fill up their tooth with bleach, have them go run around the block. Another big question that I hear the kids asking a lot is when do you use antibiotics? And furthermore, what is your go-to pain med? Will you talk about antibiotics and pain
Yeah.
meds?
Well, yeah,
The
sure. I'll be happy
pharmaceutical
to.
side of endo.
I'll be happy to. Um, there's a reason women have the babies because they tend to be a little bit more pain tolerant. It's not up to us. Us men, we're physically stronger, okay? But we tend to be a little whippier when it comes to pain medication. So if I'm seeing a man, I mean, this is a gut level feel. I don't want to make, splashing generalizations, although I just did. But as far as pain medication goes, I tend to write for Percocet. And I will tell them that you can break them in half, you can break them in a quarter, take them in quarter doses. I find that now, I mean, there are other medications out there. Tramadol seems to work. The people are using Vicodin, or I guess it's called Norco. We write for that. Tylenol codeine. I will use a Tylenol codeine medication more for of an older patient.
Do you always give pain meds just in case? I mean, do you get
Uh,
like an insurance
I,
policy,
I,
or
yeah,
if you did a
absolutely,
if you did
absolutely,
100 molars, if you did a
yes,
hundred molars, how
right,
many would get a prescription for a pain med?
100,
100. And you
absolutely.
just coach them. If you don't need it, you don't need it. If you do need
Yeah,
it, just cut them up in
absolutely.
quarters.
Absolutely. You want to over prepare people for any eventualities. My staff is very well trained and they spend a long time with them at checkout, making sure that they completely understand what is being prescribed and in what manner to take it. And, I tell patients all the time, if you have it, you don't need it. If you don't have it, you need it.
Okay, and what about antibiotics?
Antibiotics I use fairly frequently. I mean, I don't want to misrepresent that. I write a lot for Augmentin. I'll use it in the 875 strength. I'll use it in the 500 strength if their body weight isn't quite as high. In endodontics, when I started out in endodontics, Howard, there were 30 or 40 different bacterial colonies that used to infect teeth. And now, through metagenetics and all the increased genetic testing, they're finding that no, in fact, there's 300 to 400 different species of bacteria that are infecting these teeth, along with various yeasts, molds, viruses. And God, we didn't even talk about biofilms back then, but yuck, talk about nasty stuff. This is bad stuff. And a lot of times these things have been cooking in these teeth for months and months. And so there was a study out years ago by a guy named Morris. He said, and he used to say that anytime there's a radiographic lesion, then you want to pre-medicate that patient with an antibiotic prior to initiating a root canal procedure. I think that's a little aggressive, but that's been discussed by other endodontists. But I do use a fair amount of Augmentin, and then I'll back that up with metronidazole. I was one of the first guys in my area coming on board with metronidazole. That was, oh my goodness, that was back in 1990, 1989. That stuff works fabulous. It works well in conjunction with an amoxicillin type clavanic acid combination. But that's what I like to use. So the same British lady that we're discussing that I saw today, she was having a lot of problems and she was starting to get a little swollen. So I wrote her a prescription for 875 Augmentin, and I give it to her for 5 days. I don't carry her for 10 days or anything like that. And then I went ahead and gave her a prescription for metronidazole, which is 500 milligrams TID. And I told her that you can't even look at alcohol on that stuff, though. That is an anabuse medication, and it will make you violently sick if you have any residual alcohol in your system. I tell them they'll be praying to the porcelain gods and see parts of the toilet they didn't know existed. But I will give the metronidazole as a backup, and then she was instructed. Today's Thursday, Friday, and if she's not better come Saturday, she's to add the metronidazole, which seems to work well in conjunction with the augmentin after a blood level of the augmentin or the amoxicillin clavutic acid combination has been reached.
I think that was very interesting what you said about access, about, the when someone sends over a root canal they couldn't finish and they don't
Yeah.
have access. It's funny
Overcharge.
because my oral surgeon friends, they all tell me that every time some dentist tries to get out a tooth and they can't get it out and
Yeah.
they send them over to their office, they look at the flap and they're like,
Yeah.
I couldn't get it out either.
Yeah.
If that's all I
Amen.
could see.
Yeah.
And
Right.
all they do is double
Right.
the size of the flap until they
Right.
can see what's going on. Then they get it out
Right.
in 10 seconds.
Right.
But most of
Yeah.
them say, "Yeah, I can do." Because I want to ask you another thing. That's very, very confusing. You do a molar. It had an MOD amalgam, and
Hmm.
you do a root canal. You crown it. That's an easy diagnosis. But sometimes it's very confusing when people are taught that that all root canals need to have full coverage restoration when they do a root canal on an incisor, and then when they get done with that cingulum constriction, when they
Right.
get done prepping a mandibular incisor for a crown, I mean, you basically only have the gutta percha left. I mean, it looks like a grain of rice.
Yeah, I was
I
gonna
mean, they
say
base,
you're looking at the wooden end of a toothpick.
yeah.
Yeah.
So,
Yeah, God
so
bless them. I mean, I'm not going to sit here and pretend I'm a restorative dentist because that's one reason I went to become an endodontist because I thought your guys' job is just too damn hard.
so
It's a tough one. I also joke around the fact that lower anterior teeth are just too small to do dentistry on. I mean, my goodness gracious, what was God thinking, giving us lower anterior teeth? But go ahead, your question. I'm sorry.
So your question: if you did a root canal on a lower four incisors
Okay.
and you sent it back to the dentist, and they're like, if I file that down for a full coverage crown, it's going to be a grain of rice. I'm just gonna put a composite in your endodontic access hole.
Yeah.
What do you
Yeah.
think of that?
I think that's probably reasonable. I think that's probably reasonable, or else that patient's coming back in 18 months and they've got their crown in their hand, and we're looking at gutta percha sticking out of a fractured tooth that's been sectioned at the gingival crest.
I want to ask you. I want to go completely off topic, and I hope you're okay going this. But when you grew up in Kansas, everybody will tell you, everything starts out in the coast. It's either
Hmm.
California or New York, and it
Hmm.
gets to Kansas 10 years later. It seems like growing up in Kansas 25 years, and now I've been in Arizona 28 years. Seems like there's a lot of anti-mercury, not just patients in California, not just government, but there's a lot of dentists out there. And,
Yeah.
and sometimes on Dental Town, I always notice that, if someone's like has any question about mercury, the older dentists in the Midwest are like rolling their eyes, like
Right.
hippie freak from California,
Right. Right.
go eat your kiwi and your kale
Yeah.
and
Yeah. Meditate.
whatever. Yeah,
Right.
go to yoga
Go
and eat
meditate.
kale and meditate. But
Yeah.
do you think mercury needs to be looked at again? Do you think it's changing? Because you're out there I mean, San Jose, you're in the middle of Silicon Valley. You probably have the smartest, most highly educated.
Yeah.
I mean that's where Google and Facebook and Twitter. I mean,
They're all here.
those are some of the smartest people out there, and you hear not just them, but some dentists out there saying, "I don't like mercury." What do you think about that?
Well, I don't get the ADA journal, and there's two distinct discussions around mercury. And one discussion is it a proper restorative material? Okay, I think what I heard, there's 30 million tons in patients' teeth worldwide, or has been, or something. Some huge number. We've all seen it. It's a wonder. I've had them in my mouth. They're not in there now. It's a wonderful material. It's time tested. It's inexpensive. And they also say that 30% of the mercury in the San Francisco Bay comes from dental offices. And if you look just, I think, this recent September issue of the ADA, so that's one discussion. Is mercury a restorative material that we should be using in dentistry? And I don't really have opinions one way or the other on that. I mean, I think there's probably wonderful restorative materials now that can be used without picking up an amalgam triturator and putting a mercury-based filling in. I mean, it's 50% mercury. An alloy is 50% mercury. Or the other argument is, and this is the one that I'm a little bit passionate about, is mercury an occupational hazard? And there is the front page issue of September 2015, just a couple months ago, where they've got an opinion from the American Dental Association on us, the occupants who are in our operatories, us picking up high-speed hand pieces and drilling out those mercury fillings. Now, when you drill out a mercury filling, it's, first of all, it's bound organically by what silver, tin, and other metals inside the tooth. But when you pick up a high-speed handpiece, you've just weaponized that mercury. It goes into mercury vapor, and bang, it just assaults that operatory. And it is nasty stuff. Mercury is, I believe, the most toxic, non-radioactive material on the planet. And we're working around it every day by taking out old fillings. And so is the occupational risk to mercury great in dentistry? You bet it is. I have absolutely 100% belief that as dentists, we need to be taking precautions for ourselves. Now, as a patient, do I need to come running into the local, I'll remove all your fillings in one sitting dentist? No. I do not believe that. I do not believe that mercury fillings are contaminating the patient who has them residing in their mouth. That is a completely different issue, as I've already said. But the issue of, well, I'm taking out this filling. Do I need to take some precautions? Do I need to inform my patient that maybe I'm going to use some accessory evacuation procedures? Do I need to take that gray sludge of mercury that I wipe off my handpiece and maybe not take that 2x2 and throw it into my trash can so that it leaks mercury vapor all day long around my fertile bearing assistants and myself? Yes, absolutely, without a doubt.
I got to tell you a Mercury story, and my son Ryan's here. I don't know if he remembers this, but when my boys were about probably 1, 3, 5, and 7, one of my very good friends bought a 65-year-old man's practice of 40 years or whatever, and and when he got in there, the first thing he wanted to do is he wanted to take out the carpet. Because back then, going back, the AIDS issue had just kind of surfaced, and disinfection and OSHA.
Oh, yeah.
And you couldn't really have carpet. So he asked me if on a Friday after work, if I'd go help him pull up this carpet and pull out all the carpet. And I said, yeah. And brought all my boys over, and he had kids that age. Mm-hmm. We pull up all the carpet. There were balls of mercury underneath the carpet that the boys started kicking around, and they would get to the size of like a ping pong ball. And there's all of our children playing, kicking these balls of mercury, and hit the wall and split it in. I'm like, oh my God.
Not good.
Look at all the mercury in the air that had solidified, fallen through the carpet. And we were just looking at each other like, unbelievable. And I mean, it wasn't like he was some weird dentist just throwing mercury on the floor. I mean, he was a normal dentist, but the carpet showed the story. I mean, it was a ton of mercury.
Yeah, I consider it this sort of like the ugly relative in dentistry. Mercury's out there, and the occupational hazard, you can take some precautions. And if we're speaking to a lot of young dentists, I mean, listen up, guys and gals. If you can take some precautions, pretty straightforward. I have a protocol. I call it Dr. Krupp's Mercury Hygiene Protocol. And it's not
that really?
Hard. Yeah, well, I just kind of make it up myself, But yes, I do. I have a high-speed 4-inch hose that vents outside. I, of course, use rubber dam routinely. But, after we've cut that alloy, I will wear a mask, and I'm not a spiritual freak, but I do meditate. But, I mean, this is a real problem. And I will have my assistant wear a mask, and the patient will have a slow-speed evacuator in the back. And then once we cut that alloy out, we'll rinse everything down. We'll take off that rubber dam. But I do not tell the patient to swallow and have them ingest that mercury residue. I'm very meticulous about suctioning out the back of their mouth, making sure we look under the tongue, back of the mouth, everywhere. And then we will take and we'll put a napkin down on the patient's chest. We'll take the rubber dam, which has been contaminated. We'll wipe down the clamp. We'll take off the floss that's holding the clamp in the patient's mouth. We'll take out the burr. We'll take out, and it sounds like a lot of work, but it takes about 3 minutes. We then take off our gloves, and we take that material, and we take it out of the building into an environmentally safe box, and they pick it up and get rid of it. But when we go back to now complete the rest of the endodontic procedure, or actually begin the endodontic procedure, we will put on a fresh clamp, fresh rubber dam, fresh gloves, and it's not sitting in there leaching mercury vapor all day long. And the patients, they love, if you explain it to them, they love what the precautions that you're giving them. And, I want to say that I'm doing it for their benefit. I'm doing it for mine.
It's funny how history repeats itself because Rome had a huge problem. They were building lead aqueducts.
Yeah.
And late into their civilization, archaeologists are saying that, some of the lead poisoning was 50 part per million in their cranium brain. They had to be completely mentally crazy from that. And
Yeah.
there was a guy, I'm in Arizona in Phoenix. There was a guy at U of A who was doing some studies on premature babies lost.
Mm.
And he was amazed at how much neurotoxicity was in these fetuses and embryos that were
Oh, yeah.
only
It's
a few
sad.
months
Yeah.
old. And
Yeah.
and he was showing all this radiographic neurological from mercury. I thought
Well,
that,
mercury vapor, you can't see it. So, this, we all went through dental school. We all went in our sophomore labs. Can you imagine the contamination with all those typodont teeth receiving MO alloys with 100 of us in there? We were getting bathed early in our deal.
I bet there's a lot of dentists listening to this that got mad saying, Howard, why did you switch to mercury when you're talking to an endodontist and you never even
Yeah.
talked about
Yeah.
obturation?
Yeah.
So what's your same thing? There's how many different sealers are there?
Well,
Do you care if it's
I'm,
lateral condensation, vertical condensation? Are you a hot gutta percha squirter?
yeah,
Are you
yeah.
a squirter?
It's great. Yeah, I mean, I was taught lateral condensation. I did lateral condensation for 12 years, and it's a nice technique. It's reasonably predictable. I think it's controllable. And I switched over in about 1989, 1990, and I do a modified warm gutta percha technique, and I feel it's far superior to anything that's really out there. It's not rocket science. It's just a solid way to fill a canal three-dimensionally. I mean, of course, people will say, oh, you're going to break a root, you're going to crack this, you need to open it up too much, but you just have to be gentle with these teeth, and you use your vertical condensing pluggers with, a reasonable amount of force. We're not trying to lift weights here. Everything is done, in a controlled fashion, and you get beautiful results. And yes, sometimes you get puffs of sealer, and sometimes you don't. Sometimes you'll get a tertiary anatomy displaying itself, and we throw up our hands, and I think the term has been coined, the thrill of the fill. Wow, look at this. I had no idea that this thing had 3-4 branches towards the apices, and you see that kind of stuff. And I've been using just regular Kerr's sealer, and it's worked beautifully for years and years and years.
Kerr's sealer, Cybron Kerr, their
Yeah,
sealer?
I believe so. I think that's what they mix up for me, and I love it. It's definitely sensitive to humidity. It's sensitive to air temperature. I have a sealer wars, I call them. I'll have the assistants sit around and say, okay, who's going to mix me up the best sealer today? And I want something that's creamy and beautiful. It's only 83 degrees in my operatory today. Who's going to do the best? Yeah. But, I'm also, like I said, I've said this a few times in our discussion, that I got my nose out, and I'm sure other people out there have heard of bioceramics. And I think bioceramics is a wonderful sealer. I use that sometimes. It's a little more difficult. I believe Brasser's come out with a 150 gutta percha system where they can go ahead and warm obturate with their bioceramics. They have gutta percha cones that are coated. They have wonderful paper points in that system, and then the bioceramic material, the sealer, hydrophilic. It's extremely, they say, antibacterial, very high pH. It doesn't flow quite as nice as I like with the Kerrs, but it gets the job done. I use it probably about once a day.
Well, I think we've covered anything. I've only got you for 1.5 minutes, and I one of the most exciting things that's ever happened to me on Dental Town from 1998 to 2015 is you were the first one to come out and say, usually the courses are 1 hour long.
Yeah,
And it'd be, I don't care if it's an implants or TMJ or whatever. They always present a 1 hour show.
yeah,
You spent a gazillion dollars and a
yeah,
gazillion years, and
yeah,
you built a 16-hour endodontic. I think it's the first online internet curriculum ever put together that covers endo from A to Z. Talk about that. When will we see that on Dental Town?
Well, I think pretty soon. I've been talking to your people there, and and then I was advised that no, this has to be an online course because we're in 2000. At that time, it was 2013, with animations and clinical footage through my microscope, and I also filmed diagnostic procedures in the operatories, and we turned it into an online course, and that's what's going to be represented on Dental Town. And it tells a story. And I tried to make it. I worked very hard. It was my absolute passion, Howard. And I was, this has been my life for like 5.5 last 6 years. My wife will attest to the fact that I've been an absentee husband. I've been working on this thing for the last 5.5, 6 years. I absolutely am trying to pay it forward. I'm trying to have my knowledge, my expertise, not that I've done it, I'm so great, it's just I've done it a long time. I don't want people to have to sweat their own individual blood. I've already sweated the blood. Here's what works. This is my technique. It's certainly not representing that it's the only way to peel a pineapple. There are other ways to, get through an endodontic procedure, to be sure.
I've seen a lot of the online snippets and everything. I mean, it's just incomprehensible.
Yeah,
I mean, what you were able to film and your animations and your graphics. I mean, you're an endo unicorn. You really are. I mean, you
Thank
are.
you very much. It was my pleasure. Let me tell you, it was a lot of work, and I loved every minute of it. We went through ADA CERP approval, AGD approval, went through exhaustive applications on those, and
I think people will be watching that. Seriously, dude. I think a century from now, people will still be watching that. I really do. I mean, there'll be parts of that I mean, so much of that what you did was timeless.
Thank you. Yeah. Thank you very much. It was my pleasure.
Can people call you or email you?
Well, I mean, you can get a hold of me, info@Success in Endodontics.
Info@successinendodontics.com.
Info@successinendodontics.com. And we have a website, and we have a Facebook page, and we've been doing all that. And
what's your Facebook page?
Success in Endodontics.
Successinendodontics.com.
Yeah. Yeah, and I'm pleased to have an affiliation with you guys. I mean, you, Howard, have done a great job. I mean, you've taken technology and you've ran with it, and you've taken dentists, and we're all used to being little independent entrepreneurs sitting on a little independent operatories, and you've brought the community together, and you've done a beautiful job in that. And you're to be congratulated for what you have done and establishing your blogs and your network, and my hat's off to you.
Well, it's definitely my passion too. I mean,
yeah. It's fun when you find your passion. It's fun.
I've been on Dental Town 5-6 hours a day, every day, 7 days a week since 1990. I don't care if it's Sunday, Christmas, Easter, Hanukkah. It doesn't matter to me. But hey, we're in way overtime. We're 3 minutes over. Hey, really, dude, I think you're an amazing guy. I had so much fun with you in San Jose. I'm glad Dionne Warwick pointed you to that town. And thank you for this masterpiece program you put together. That's really. I think it's the only one of its kind. I don't think there's.
Oh, it's the only one in the solar system, Howard.
It's definitely the only one in the solar system. There's nothing else like it you'll be able to find on the internet. It is truly just. I mean, Hogo and me and Giacobi, we're just looking at stuff like, damn.
Well, it's a pleasure.
Damn.
It's a pleasure.
And on that note, damn. Thanks, Jeff, for all that you've done for Endo.
Okay, thank you so much, Howard.
Bye-bye.